Hello, everybody. We're going to get started in just a minute. I'm giving people a couple more minutes to get in. I'm going to do a little spotlighting of myself and Dr. Savage so that you see us primarily. And as we go through the webinar, if you have questions or just want to ask us something, you can use the chat button, you can use the Q&A button. We'll be trying to check those periodically and answer any questions that come up. Um, I'm just going to get going. I'm Rebecca Dunsmore-Sue. I'm Chief Medical Officer here at Genève, and we host these Menopause 201 webinars every month except December because I need a break sometimes. And they're really meant to be free educational information. We talk about sort of the evidence for different topics. We have a whole bunch of old ones on YouTube. You can access that via the website, and there's a button that says See Older Webinars. Tonight, I am thrilled to be joined by Dr. Lisa Savage, who's one of our medical directors at Genève and a good friend. And Lisa, why don't you introduce yourself?
Hi, everybody. I may have met some of you before on a previous webinar, but I'm glad to be here with Rebecca for this one. I'm an OG with Genève. I've been with Genève since 2019 and doing menopause care and evolving with the specialty and the company. Before that, I was in private practice in Austin, Texas for many years. And I always loved menopause and I always did a lot of it. So this is a natural fit for me at this stage of my career. I'm still learning, and this webinar prep was just more of that. I got to read some articles chosen by Rebecca. Thank you very much. And just like with our ABOG or board certification or maintenance of certification, I read things that I might not otherwise have come across or read. It kind of forces you to do that. So I think as lifelong learners, we need to do that. And so I welcome this opportunity to go through some of these articles and chat with Rebecca, which is always one of my favorite things to do.
So, in choosing what to talk about tonight, there were a lot of articles, and obviously we only have an hour. So, I narrowed it down to four. I tried to cover some different topic areas and areas that are getting a lot of play right now. So, I picked one in the cardiovascular arena, one about testosterone, one
The T
about
train.
yeah, the T train, one about DVT, and hormone therapy, and then what was the fourth one I picked? I don't even remember. Hold on. Oh,
Oh, the dementia one.
oh yeah, and what about dementia and
That was
menopausal
a
hormone
that was a
therapy?
good little segue into dementia. I can't
Yeah,
remember.
I can't remember. Um, there are also some interest. So one thing I would recommend reading, I didn't want to do it for this because it's pretty straightforward, like study results, but elazinitant, which is called Linquet, is the brand name, came out this year, got FDA approval. It's in the same class as Veoza, also an NK receptor antagonist, and they published their pivotal data from their studies last year. So it's just interesting to read their data and understand how well it works for hot flashes. They have some sleep data, but also looking at their safety profile, because if you're choosing between the two, it's interesting to know, which one has more liver effect, things like that. Didn't seem like the right article for this venue, but I think that it's worth reading that data, especially if you're working in the menopause field and you have patients who can't take hormones and are looking for other alternatives. So I guess we're going to start, Lisa, right with
The T
testosterone.
train. I want
Just
to jump right
jump
on the
right
T
in.
train. Jump on the T train. Yeah, this article on testosterone and pre-androgens by age and menopause stage is really important because, as we all know, social media is full of the purveyors and promoters of
Mhm.
testosterone.
Yes.
And Becca and I were both at the Menopause Society meeting. Maybe a number of you were as well. Dr. Susan Davis is kind of like the testosterone queen and guru. And
Mhm.
hers was one of the most well-received talks. And I know I certainly learned a lot.
Mhm.
And so this article is reflective of that topic. So yeah, I wanted to start with this one so that we're sure to get to it and talk
Yeah.
about testosterone.
Yeah, and so this article, it comes out of Dr. Davis's research group. The lead author on it is Wang, but and we will, in the follow-up, we will put all the citations for these articles so you guys can find them as well. It's open access. It was um, uh, published in Lancet Biomedicine. What they did, so they have a large research group on testosterone, and they actually have an ongoing, like, prospective trial looking at testosterone therapy in women. But this is one of the things they did sort of leading up to that. So it's a study they call the Australian Women's Midlife Years Study. And so the larger study has like 5 or 6 thousand women in it. This is a subset that got, oh, the title of the article is Testosterone and Pre-Androgens by Age and Menopausal Stage at Midlife, Findings from a Cross-Sectional Study. So 1,400 of the women in the larger study agreed to get blood draws. And they ranged in age, and I'm trying to remember that. I think the
Like
age levels were from 40
55
to
to
60. Yeah. And so they got blood draws and they just looked at the levels of testosterone, androstenedione, which I can never say correctly, and DHEA in age groups across that range to sort of make charts of, what is it testosterone doing? Interestingly, I'm going to give a little history on this. They've also done this study in younger women, and we'll talk a little bit about that data as well because they mention it in this article.
So, Becca,
Mhm.
talk about how they measured the testosterone because I
Yeah.
think that's a really important point, and it's also
Mhm.
a point that I make with patients in our menopause appointments about lab equipment and
Yeah.
what you're using to measure female levels of testosterone.
That's it. That is true. It is a really good point. And Dr. Davis brought that up at the Menopause Society as well, saying we cannot use free and total testosterone available at LabCorp to accurately um, measure testosterone at female levels. It's just not validated at those levels. So for this study, they used liquid chromatography measurements. These are hard to access for those of us in practice, but they have it as a research assay. And these are known to be a lot more accurate at female levels.
You know, so many patients come to appointments and they're saying, but they told me my level was zero.
Yeah.
You know, my testosterone is zero, and therefore I need testosterone. So I think it's a
Mhm.
really good point to make that they use this advanced technology to
Mhm.
measure levels. And it's a good message for patients that lab equipment is not designed to look at female levels. And so
No.
zero may not be zero.
And zero
Um,
is actually within the normal range for free and total testosterone
exactly.
because of that.
Exactly. Yeah.
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 No, that's a really good point.
I was intrigued by the fact, and I tell
Mhm.
patients this too. I had the opportunity twice this afternoon.
Mhm.
Testosterone does not drop at menopause.
No,
I always
that
just
was
put
their
that
main
out there,
finding.
and then I go full stop, and then I go, let me say it again, testosterone does not drop with menopause.
Hmm.
And that's really surprising for a lot of people to know.
Hmm.
And I always say, tell me if this is accurate,
Hmm.
that it goes down slowly from our 20s to our 80s, just like in men. But
Hmm.
it doesn't
Sort
have a
of.
big, sorta, it doesn't, because, oh yeah, it goes
Yeah,
back up.
there's
We're
a
going to
bump.
talk about that.
Yeah.
But it doesn't have a big plummet the way our
Mm-mm.
estrogen and progesterone do.
No, and that's a really good point. And this study really shows that they have enough women that they can actually chart it out. And, when they did their earlier study in the 18 to 35-year-olds, they showed about a 25% decrease in testosterone levels between the ages of 18 to 35. Between the ages of 40 and 60, they show another 25% decrease. We're on a slow decrease over the course of our lives. This is true in men too. So it's not just us. This is what happens. What they found, which was interesting and has been hinted at in previous studies, but was not really well defined, is that it then actually bumps back up in our 70s.
Who knew?
And who knew? Not a huge amount, but like that slow decline bumps back up and then starts going down again. But you mentioned it doesn't drop with menopause specifically. Yeah, it's dropping across these years, but they were actually able to straw stage every single woman in this study. So they looked at perimenopausal women, menopausal women, postmenopausal women, and they looked across those straw stages. And the actual timing of the menopausal event for these women did not impact how they measured out. And that's really important because I think, there's this impression that as your estrogen and progesterone are going down, women also think their testosterone are going down, but it's coming out of different cells in the ovary. It's coming out of the adrenal, and it's really sort of on its own separate pathway. They did not have patients who had, they did have patients who had had their ovaries removed in this study. And that is a different curve because the ovaries do make some testosterone. So if you take them out, they had lower levels at all age ranges. So there's a different discussion to be had there. That wasn't as big a subgroup. So they didn't make any large conclusions based on that.
I always like to point out the ovarian production of testosterone when I'm counseling patients having hysterectomy for benign disease
Mm-hmm.
about conserving their ovaries.
Yeah. Yeah.
Because I think so often people will say, well, you're past 50, so let's just go ahead and remove your ovaries at the time of a hyst for something
Mhm.
benign. And I would beg to differ. I always say, well, I mean, there are pros and cons to either side. But
Right.
let's not forget about the other things that ovaries produce, like testosterone,
Hmm.
and you're going to completely lose your source of it from the ovary if you have that
Right.
oophorectomy. And maybe that's
Yeah.
not necessary.
Right, exactly. And some is made in the adrenals, but a large proportion of it is made in the ovaries in postmenopausal women. And so it's definitely bears considering in that situation. Um, yeah, and I think the other thing that was interesting is they're able to look at androstenedione and DHEA as well, because I
Mhm.
think those get a lot of play also. Um, the only thing that actually dropped at menopause was androstenedione, but it didn't seem to impact testosterone levels anymore. And DHEA didn't drop at all. DHEA, but it turns out, they pointed something out which I had not known until I read this article, which is DHEA is only 10 to 20% made in the ovaries. It's primarily made in the adrenals. So you're maintaining that DHEA production no matter what. So yeah, I thought they did a really good job of sort of going through. They have beautiful charts. They're great to look at because you can see a smiley face of testosterone from 40
That's
across.
appropriate.
Yep, because it starts to go back up around 58, 59. And it gives us concrete information with a graphic that I have actually shared with patients. Like I think it really helps them to see it visually and say, look, this is the smiley face of testosterone during this time. You're not going wildly down. It doesn't speak to what testosterone can do. This was purely a cross-sectional study, and they will probably in 2026 release the results of their larger study looking at testosterone in terms of sexual function, well-being, muscle, bone, all those things. They've done previous smaller studies where they look at whether it impacts those things and haven't shown a whole lot of benefit for it, but they're doing a rather larger study right now. So I'm really hopeful that that data is coming out this year because I think it'll be incredibly helpful. They do just the most amazing research.
On that note, I just wanted to read
Hmm.
one of the things from this article. This is for now, and of course,
Hmm.
more is coming. Stay tuned. But this shows that this has not shown testosterone supplementation confers other health benefits, such as prevention of muscle loss, cognitive benefits, or improved mood or increased bone density.
Right.
And I think that's important. And Dr. Davis made that point at the Menopause Society meeting. She
True.
had one slide that just said it is not at this point to be used for this, that, and the other, bone
Right.
loss, muscle mass. And I think that most people who want to use it, primarily they're looking for libido. But
Hmm.
I think that these other things like muscle mass, they can maybe be achieved by overdosage, but I think
Hmm.
it's important to tell patients about just that. It's not
Right.
indicated for energy,
Right.
mood, bones, or muscle
Right.
mass.
Yeah, and in their small study that they did before they designed the large study they're currently running, they did multiple different doses, and the only time they saw any improvement in muscle mass or bone was when they got to near male ranges. And then, of course, you're risking a lot of the side effects, and we don't know about the long-term health of that. So I think stay tuned. There's going to be a lot more information coming out in the next year or two on this from their big studies. So really exciting research. Shall we
So we
move
wanted
on?
or do we want to take questions on
Oh
this
yeah.
article? Do we want to
Yeah.
do that and
Yeah,
just sort
let's
of wrap
definitely
up
see if
this
anybody
article?
has questions.
Yeah, on this
Um,
the testosterone
yeah.
article.
And I'm not seeing anything in the chat. I don't know about you.
Mm-mm.
I'll
No,
check the
last
Q&A.
chance to ask a T question.
Not the last chance.
Okay. Yeah, we'll do
Oh,
more at the
Gail
end.
said, sorry, joined a few minutes late. What's the article? It's in the chat. So if you look at the chat, we put the title there. All right, shall we move on?
Let's move
And we
on.
can take additional questions at the end. We just
We
wanted
will.
to take a quick pause to make sure that we're in a burning question about this one.
All right. The next one, safety of menopause hormone therapy in postmenopausal women at higher risk of VTE, a systematic review. I
Ah,
think this is
yes.
a hot topic because, we're
It is a
hearing a
very
lot
hot
about
topic.
transdermal conveys no additional risk. And even if I've
Mhm.
had a pulmonary embolism, I should be able to
Yeah,
use transdermal estrogen.
yeah,
And so I think this is very timely.
it is. It is. And I'm gonna, so this one's harder for people to get to. It's one of the reasons I pulled it. It's from Climacteric, which is the Journal of the International Menopause Society, and you have to be a member to get access or buy the article. We will put the citation up anyway, but it's not as easy to download, although if you have like institutional access, you can get it. Um, and, I agree with you, Lisa. I have heard this over and over again from patients or even from other physicians. They're like, oh, but transdermal doesn't increase your clot risk. And what I always remind them is that we do have a really good study that shows that transdermal in low risk women at 0.05 or below does not seem to increase clotting factors or clot risk. And that was a large scale study. That's a great study. That is totally true information. The big key phrase in there is low risk women. Women who had any risk for DVT or a previous DVT were not included in that study. And so we really need to be cautious in extrapolating that data to someone who might have a risk factor. And that's why they did this systematic review. They wanted to see what literature was out there to speak to those women.
So let's talk about what constitutes a high
Mm.
risk for VTE. What were their
Yeah.
categories? And they're all things that we encounter in everyday
Hmm.
practice.
Right.
So even if somebody hasn't had um, an embolism or some kind of a thrombosis event, there
Right.
are certain very common conditions that are associated with higher risk.
Right. So the categories that they were looking for articles in were overweight and obesity, smokers, personal history of VTE, family history of VTE, type 2 diabetes, surgery within the last 3 months, an underlying cancer, and any known or acquired thrombophilia. So whether it be factor V Leiden, prothrombin gene, or even like antiphospholipid antibody syndrome. So those were what they searched on. They did not find articles on all of those things, and
I
we'll talk a
know
little bit
that
about
was
that. Yeah.
very, very interesting. There's
Yeah.
um, room for improvement on the
A
amount of
lot of
data
room for
we have.
improvement here.
That's the thing,
Yeah. And they
what's
said
your
that too.
approach? Yeah, they
Yeah.
did. They admitted that is that, we need to clarify this a little bit more.
Yeah.
But I think it's important to differentiate somebody at average or low risk
Right.
versus someone who already has a baseline risk that's higher.
Right.
But the one thing that was super clear, which we already knew, is that transdermal over oral
Yeah. Yes.
every single time,
Yes.
right?
In every category, transdermal had less risk than any oral form. So oral estradiol was really not that much better than conjugated equine estrogens when they could compare them. But an oral estrogen of any kind definitely increased risk in all of the categories that they could look at. Um, and I want to qualify the discussion of this paper by saying they didn't have a lot of studies to work with here. So when they did their search, of course, they came up with like 5,000, but after excluding anything that really didn't apply, they ended up with 10 studies
10
to do this.
studies, and they were
10
all very disparate types of
and very
studies.
disparate. Six case control studies, two randomized controlled trials, and then one randomized controlled trial with a nested case control study and a cohort study. But what they were very clear about that there were significantly different studies. They were different in their definition of menopause, the doses and forms used. Um, They did it for this analysis, excluded studies on premenopausal women. They excluded oral contraceptives, vaginal estrogen, sub-Q or intranasal estrogen because those are not routinely used. And the one thing I did appreciate that anytime they were talking about someone with a personal history of DVT, it had to be patients diagnosed with imaging, not just clinical history or blood markers. But they also looked at the quality of the articles and were not spectacularly nice about the quality of the articles. I think they said like low to moderate confidence in the results. There are different ways you can look at a randomized controlled trial, whether you assess the results as low to by confidence based on like the confidence intervals and how the study was designed. There are other ways to do it, but they not great data to work with, sadly.
So what do we do in practice? We
Hmm.
don't have great data, but so what do you do if you have somebody who comes in and say they had
Hmm.
superficial thrombophlebitis
Yeah,
and they're desperately suffering from menopause
right.
symptoms? Is there room for nuance in prescribing with caution, or is this a
I
hard
think there's always
no?
room for nuance. No, I think there's always room for nuance. And I don't consider superficial thrombophlebitis a big risk. I think, you know, that's not a DVT. But I'm much more cautious with someone who's had a DVT. And I think there's some data out there that, oh, if it was provoked, it's okay. But something it happened. Yes, there was a provoking incident, but a lot of people have that same provoking incident without developing a
Oh,
DVT.
I tell people that all the time. Like, well, I know
So
that you were
something
on a
may be different
transcontinental
about them.
flight, but a
And
lot
I
of
also,
people were on that flight that didn't have a DVT.
yeah. And I also talk about the fact that, even if maybe it was a totally random occurrence, damage has been done to the vessel. There's scarring. So we can't say that you now aren't at higher risk. These are all the discussion points. Have I never put a person who had a personal history of a DVT after breaking their hip and being immobilized for 8 weeks onto estrogen later on when they're totally mobile? No, of course I have. But it's a very deep and complex discussion with a lot of risk benefit discussion. And some of that is really theoretical, as this article proves. Like, it's not like we have a lot of great data to go on, right?
No, I know. I do think people make a lot of
Hmm.
provoked versus unprovoked, but
Hmm.
but the fact is that once you've had a clot,
Hmm.
you remain at higher risk for
Hmm.
another clot, no
Yeah.
matter what. And so
Yeah.
even if it was provoked, that
Yeah.
doesn't give us a pass, but sometimes I think there's this idea that provoked
Hmm.
means don't worry about
Right.
it, and that's not the case.
Yeah. Oh, funny story. I had one patient come to me and say, "No, it's okay. I had a provoked clot." I said, "Provoked by what?" She said, "By birth control." I said, "Yeah."
Good one.
So estrogen caused you a clot.
That's a good one. Yeah, provoked by what? Yeah, I
Yeah.
always just say, "Tell me about it. What were the circumstances?"
Yeah.
And then you get some good info.
Yeah. So, the studies so they were able to find information in this study on several of the categories that they preset. Um, and I'm going to go a little bit into some. I'm going to spend the most time on people who have the personal history of clot because I think that's the area we're seeing a lot of confusion about right now. In terms of overweight and obesity, they had two studies to look at. They didn't see any significant risk with transdermal estrogen across all weight categories. They did see an increased risk with both oral estradiol and conjugated equine estrogens. The risk estimates were about the same for those two in obese and overweight women. And the risk got higher as the BMI went up. So there does seem to be a relationship there. They did look at smokers. They found only one study. And that study was conjugated equine estrogens, mostly with medroxyprogesterone acetate. And the odds ratio on that one was 1.73, which was technically significant. The 95% confidence interval doesn't cross one. So there may be a slightly higher risk with that particular drug. We don't have a transdermal study in smokers specifically. So, hard to say. I will say that having read this article, that odds ratio for increased clot was one of the lowest positive odds ratios I saw. Like a lot more in a lot of the other categories, like the odds using an oral estrogen was in the sixes, sevens, one was even 17. So I don't think it's a huge increase in risk in smokers.
I was surprised by that. I thought that
Hmm.
one would be one of the higher ones, and it was the lowest.
Yeah, and with CEE plus MPA, which is usually the
Mhm.
highest in terms of clot risk.
Yeah,
So, yeah, I think, it made me a little more comfortable saying, I know we use hormone therapy in smokers. It's not a contraindication, but definitely with transdermal, I think there's probably pretty limited risk.
yeah. There's a question. What do you quote as a risk of DVT for transdermal estradiol over 0.05 patch dose?
I don't
Or
know
what
what to
is more
quote.
increased risk versus lower doses? Yeah, I don't
We
think
don't
we've had
we don't
that.
know. We don't
Yeah,
know. That's the thing. I think probably all transdermal preparations are relatively low risk, even the 0.075 and zero point 0.1. However, I think it's only at 0.05 and below they were able to show absolutely no increased risk and no change in clotting factors in that one large study. And I have to pull that study again. I haven't read it in a couple years, but, I don't think it was like once you got above that, everybody got a clot. It was minimal difference. But, I do tend to, especially in someone who might have a risk factor, stick under the 0.05.
well, I think that with everything, there is usually some dose dependent
Mm-hmm.
association, whether it's a side effect or a complication. I think that usually there is dose dependency. So there's that.
Yeah.
But I wish somebody would do a study of the higher two doses
Mm-hmm.
to focus on those because we do end up using those in a fair number of
Mm-hmm.
patients. That would be
Absolutely.
nice. Yeah.
Yeah. I think we should move on to what everybody's waiting for, which is personal history of VTE and what we now know.
Okay, what should
So,
we know?
what do we know? Not much. That's the sad fact. So, they did have they had two studies to work with in this category. Um, and neither of them, neither of those studies had any specificity on whether the VT was provoked or not, the setting of the VTE or anything. They just had a radiologically diagnosed DVT. Um, one of them was a randomized controlled trial. Great. It was ended early because of safety concerns. So this was a randomized trial of using oral estradiol plus a progestogen that I don't think we have in the US, but may be available elsewhere called norethistyrone. And the odds of clot in that group, repeat clot, were 8.5, the odds ratio. Very significant compared to a placebo. So it was actually placebo controlled. And they do say that in this study, about 25% of the patients who were in there did have a history of some form of thrombophilia, but they also had a previous clot. Another one, it was actually a good design. So it was actually done in a DVT clinic. So it was women who had a previous history of DVT, and it was a retrospective cohort study. And so they showed a hazard risk of 6.4 for oral estrogen. However, they did not show an increased risk with transdermal estrogen or transdermal estrogen plus medroxyprogesterone acetate. So the hazard risk with those two was 1.1. So I thought, hey, this is actually pretty good data. I need to look deeper. So I actually pulled the study, and I know it's not one of on our list, but it turns out this is a study from 2011. The total number of women in the whole study looked good. It was 1,023. The total number of women taking estrogen was 130, and the total number of women taking transdermal estrogen was 100. So I just bring that up because the other 900 people in this study were controls. So we get good numbers when you have a 1 to 9 match. You get some statistical power. But realistically, you have to say you cannot use this as evidence that it's safe because you would be basing all of that evidence on 100 women. And that's just not enough women to be able to say that with confidence. It suggests certainly that transdermal is safer than oral, but it's certainly not something where I would take this data and say, yeah, it's fine. There's no risk here.
Yeah,
It's just not enough
900
data.
controls. When you
Right,
look at the total number in the study,
right,
you sort of assume that it's kind of half and half controls
right.
versus study patients. I was shocked when you pointed that
Yeah,
out, that the vast
yeah.
majority of the total patient population were in the control arm.
Well, and it was not really cases and controls because it's a cohort study, so exposed and not exposed would be the correct terminology. And that's why those are the numbers, because these are women who've had a DVT. Not many of them are taking
I was
estrogen
going to
and they
say,
look
well,
backwards.
how did those people get on the HRT? Or maybe they
Somebody
were
gave it to
on
them.
it.
Yeah,
Somebody gave it to, yeah. So I
right,
was amazed at that too. It's like, how did
right.
they end up on it? But I guess they did.
And
So we have a little bit of
we
data.
have a little bit of data, but we honestly don't know their level of exposure because that data was not involved in this study. So we don't know if they were on it for 3 months or they were on it for 3 years. We don't know any of that. So really just not high enough quality data to be able to make any conclusion.
Yeah, because probably the patients who were on it were asked if they were on it or they used
Hmm.
pharmacy records,
Hmm.
but we don't know for certain, like you said, what their dosage duration was.
Hmm.
So it's
Right.
hard to say.
Hmm.
Yeah, it's still it doesn't generate a whole lot of confidence for prescribing to somebody who has had a DVT.
No, not
So
really.
yeah.
So the last category they were able to find data on was studies on people who had thrombophilias. Um, so they they searched on a lot of them. They were able to find two studies that looked at transdermal versus oral in factor V Leiden, multiple, both heterozygous and homozygous, and then a prothrombin gene mutation study. Um, all of these were done. So, in all of the studies that they found, oral estradiol, oral CEE, whichever was used, increased clot risk. Um, the transdermal did not seem to increase clot risk in this collection of studies, but these were very heterogeneous studies. A lot of the patients were probably heterozygous for factor V Leiden, so what their baseline clot risk is probably a lot lower. They were not able to find any studies on the acquired thrombophilias, so we don't have information there. Um, and these were all people with these gene defects, but no personal clot. So that would be a whole separate category of patients. I didn't have time to look through all of these studies, but even they felt like the information in this category was pretty low confidence. Just not enough patients, wide confidence intervals. I will comment that the International Endocrine Society, so I did a sort of deep dive on DVT this year for our Genev providers, and the International Endocrine Society notes that heterozygous factor V, it's probably safe to use transdermal estrogen. They're probably at relatively low risk. Other clotting disorders with no personal history and no strong family history of clot, you're probably safe to use transdermal estrogen. But with significant counseling. Um, but that's all we've got. That's an expert opinion. It's not based on tons and tons of data. And so if I'm counseling a patient like that, I really say, look, this is an expert opinion. This is the little tiny bit of data we've got. I can't tell you this is totally safe. And we need to make this choice carefully.
And that's what I would say. Let's start low.
Hmm.
Let us start at the lower end of the dosage spectrum,
Right.
and then proceed cautiously from
Yeah.
there. Yeah.
I actually tell them, let's start with alternatives. And if we really can't
Oh,
control,
yes.
then we go.
Great idea. Great idea. Let's not forget that we have those other options. Um,
Hmm.
it's so, especially for the people with primarily vasomotor misery.
Yeah.
We don't have to take the risk if an alternative might work out. Good
Hmm.
point. Good point.
Yeah. And then, the other categories that they mentioned, so underlying cancer, family history, type 2 diabetes, there weren't any studies to pull. So, no data. Don't know. I see there's a question. So we're sort of at the end of this discussion. So let's look at our questions in the
Yeah.
chat. You want to shoot me something?
Do you ever suggest patients, this is a good one, start
Mhm.
Eliquis to be able to use HRT safely? In other words, and I've had patients say, oh,
Mhm.
but I'm on Eliquis, so
Right.
therefore I can use it. And
Mhm.
let's address that because it comes up quite a bit in clinical
It
practice.
does. And again, very little data to go on. Two of the studies that they looked at in this systematic analysis, patients were allowed to be on anticoagulation, but they weren't able to separate those patients out and see if they were at lower risk than someone who wasn't. In I've had hematologists tell me it's fine to start her on estrogen. She's going to be on Eliquis for life. And if the hematologist says that, I might be a little more willing. Somebody else's lawsuit. But I don't know if we know. Like in theory, yeah. But what if, she forgets her Eliquis on her trip to Europe, but not her estrogen for a week?
Hmm.
What
Hmm.
happens then? I think you just need to be very cautious. But I'm not sure I would start an anticoagulant to take hormone. Like that is just, it seems like a really big gun for something we have other options for.
Well, you know what? And people on anticoagulants can fall down and have a head bleed.
Hmm.
And, those drugs are, you have to really be cautious with the use of those. We
Hmm.
can't be cavalier and just say, oh, well, let me just put her on an
Right,
anticoagulant to mitigate the risk of a
right.
blood clot. Oh, no, no. One thing I will say is that if I have a patient in one of these maybe categories and they're
Hmm.
seeing a hematologist, or maybe if they're not, I
Hmm.
ask them to get a hematologist to weigh in.
Hmm.
And if they're already seeing somebody, I say, you know what, would you please have them sort of give or deny permission for this?
Hmm.
So that's helpful. I mean, you can reach out to your hematology colleagues
Hmm.
and, get them to be a part of the team
Right.
and, give their opinion.
No, exactly. And with the caveat that the misery of menopause or perimenopause is often not their bag. So they may not recognize the importance of quality of life to women who are going through this. But, when I've asked for input from a hematologist, I often make it quite clear. Look, we've tried X, Y, and Z alternatives. She's not sleeping. She's unable to be functional at work. Like this is severely impacting her quality of life. So we want to make this consideration. What are your thoughts?
Good
We can
point.
be a team player for the
Mm-hmm.
patient in that
Mm-hmm.
sense.
Yeah.
Um, but yeah, it was an interesting. I was so excited by the meta-analysis, and then I actually read the meta-analysis, and I'm like, yeah, these are not great studies that they pulled together. Um, I would love us to do large scale studies, but this is really hard. You really, as shown by the one that tried, struggle to randomize people to hormone or not who have a high risk for taking hormone. I'm not sure you'd ever get it past an ethics board. So we're going to be stuck with cohorts and retrospective studies.
Any other questions on the blood clot topic? All right. Should we move on to dementia?
Gotta love dementia.
Gotta love dementia because, a lot of patients are wondering, and I've had older patients, especially with some mild cognitive impairment, and they come in and they want to start
Mm,
HRT kind of outside the window, but they're desperate for something to help with their cognition.
yeah. Yeah, no, I've seen that too. And actually, just a historical aside, some of the early studies with conjugated equine estrogens, they actually went into nursing homes and treated like 85-year-olds with dementia with estrogen to see if it made it better. Um, and it did a little bit for a short period of time. Um, Now, they didn't study it long enough to see if they give them all a stroke, but it's just an interesting historical note. They did this in like the 50s and 60s.
Mm.
So
Mm.
this article that we're going to talk about is another systematic review. This one's published in Lancet. It's called Menopause Hormone Therapy and the Risk of Mild Cognitive Impairment or Dementia, a Systematic Review and Meta-Analysis. Um, an extremely well done systematic review. I was very impressed with their methods and the way they assessed studies and graded them for quality. Um, they specifically looked at postmenopausal women, but did not include premature ovarian insufficiency because the data for that is very different and separate. And there is proven benefit for hormones preventing long-term dementia risk in POI. And those are patients who are at higher risk. So women who have premature ovarian insufficiency should be put on hormone replacement at least until the natural age of menopause. And I like to say that whenever I get the chance.
Be
And there
generous.
were,
They need generous HRT.
yes, there are no studies in here to assess whether testosterone helped. There were no studies that had testosterone in it. Um, and again, this is a systematic review because you can't do an RCT on this. You can't say, hey, well, you could. I would love to do it. I would be the first in line to say, hey, give me a subset of 10,000 women and let me treat half of them with HRT for the next 30 years and the other half not and see what happens. Nobody's gonna fund that. Um, so this is what we got. So I'm going to go through a couple of facts about what they looked at. So it was 10 studies total, again, only 10. The studies range from the year 2000 to 2025. Only one was a randomized controlled trial. It was the WIMS trial, which is a subset of the WHI, which looked at mental health or dementia, and then 9 observational studies. And they did the type of, I know exactly. I agree. Sign me up. They did the type of grading where they looked at um, the certainty of the evidence based on study size and study design and things like that. And they used 2 separate graders to look at the evidence. And so across all of these 10 studies, there were 1 million women studied. So this is a lot of data. Um, and you'd think we'd get pretty good answers from this. So they looked first at all-cause dementia in the estrogen-only category. So they also separated out estrogen only and estrogen plus progesterone, which is actually important because they behave differently. So in the estrogen only category, they looked at all-cause dementia, and there was a slight trend towards an increased relative risk at 1.12, but the confidence interval crossed 1. And there were a lot of women in this, so realistically, that's not statistically different. And they also did a thing where they looked at clinical thresholds for absolute risk. So they said, what does this actually calculate out to in terms of number of women that would experience this outcome? And they said this effect, if it were true, is well below a clinical threshold. We just wouldn't notice it in the general population. Um, and the result was similar for combined menopausal hormone therapy for all-cause dementia. They looked also at Alzheimer's disease separately. And they actually had a lot of data for this. They had 4 observational studies with 800,000 women. They looked at estrogen only and saw a relative risk of 0.95. So again, really no difference in all-cause dementia. Crossed 1, the confidence interval. And for combined menopausal hormone therapy here, it was 1.11, not significantly different. So we had a lot of women in this category and no statistically significant difference was observed. They also were able to look at how long it was used. So how long did they use the hormone? So for estrogen only and combined menopausal hormone therapy, and they broke it up into 0 to 5 years, 5 to 10 years, and 10 or more years. For 0 to 5 years or 5 to 10 years, the relative risk was slightly above 1. And for 10 plus years of use, the relative risk was slightly below 1 at 0.93. But both were non-significant, crossed 1, so no big difference there. And then age at initiation was also able to be used and also didn't yield any significant results. So what I am saying with that very long-winded explanation is that menopausal hormone therapy doesn't cause dementia. Menopausal hormone therapy doesn't stop dementia. As we have said for many years, and as the Menopause Society says, and as the International Menopause Society says, starting menopausal hormone therapy at the time of menopause is neutral. Doesn't prevent it, doesn't cause it. It just is. The WIMS trial does have data for all-cause dementia going up if you start it later in years. So just keep that in mind. The one randomized control trial does show an increased risk if you start it 10 or more years in. But when you combine it with all this observational data, that sort of came out in the wash. Um, so that's dementia.
So to summarize that, I would just say it's neither here nor there.
Yeah.
It's not going to help. It's not going to hurt.
Yeah.
But I think that, everybody is so hopeful that it would be
I know.
helpful.
I know.
And I think that's something that we have to just accept with resignation.
Yeah.
That but fortunately it doesn't hurt,
Yeah.
right? And we're going to
Well,
use
I
it for
think,
these other things, but for
yeah,
dementia, cognitive decline, it's probably just neutral.
no. And I think there are a couple reasons for that. One, cognitive decline is a multifactorial thing. They're not all the same. And maybe there are some that respond to estrogen, but there are many others that don't. I think that, we all get hopeful because of that premature ovarian insufficiency data, right? We see these women and they get prevention, but they're a different category. They start with a different risk. They use hormones a lot longer than most women. So we're not just talking, this study had some women in the 10 plus year category, but premature ovarian insufficiency, depending on when they go through it, they could be using hormones for 20 to 30 years. That might actually make a difference. We don't know. We have no study that does that. I'd love to do it, like I said before. Sign me up. I will run that randomized controlled trial. I'll be dead before it results, but that's okay. Um, but yeah, no evidence has ever pointed to protection except in that one category of people.
I will point out that for women in the throes of menopause misery
Hmm.
who are not sleeping and they have that brain
Hmm.
fog, the cognitive
Hmm.
difficulties, and they're scared to death that they have early onset dementia.
Hmm.
And then you put them on HRT and they're sleeping better and their thinking clears up and they
Right.
feel so much better.
Hmm.
But I think it's important to point out to women that if they're in the throes of the symptoms and they're feeling cognitively off,
Hmm.
if you do formal cognitive testing on those women, it'll be
Hmm.
normal.
Yeah.
So, we can reassure patients who think they're, getting
Right.
dementia when they're in the acute phase of menopause
Right.
symptoms that they're not, and they're probably going to feel better and sharper with
Yeah.
therapy.
Yeah. And another good point that you made in that is one of the things that happens through this transition is a lack of sleep. And for most women, they get a handle on that, but long term sleep deprivation can increase your risk of
A
dementia.
hundred
So that
percent.
may be one place where estrogen may have a long term role in helping to reduce risk factors for dementia. It's not directly preventing it, but if someone really genuinely can't sleep and it's going on for years and years and years, that impacts their longevity, their cardiovascular disease, their weight, and their dementia risk. So
Everything. To
always
me,
ask about
sleep
sleep.
is so central. It's so
I
central
know.
because all these downstream symptoms and consequences come
Right.
from a lack of sleep. So
Yeah.
there's an indirect effect.
Yeah.
Yeah.
No, absolutely.
All right.
All right. Do we have any
Some
specific questions
questions.
on this one?
Yeah. So there's a comment about HRT, but it can hurt if
Mhm.
starting more than 10 years out from menopause,
Yeah.
correct?
There's some
Correct.
data from the Women's Health Initiative, the WIMS study, that shows that all-cause dementia does go up if starting more than 10 years out. And there's some thought that that may be a vascular dementia effect. So we know that cardiovascular disease has already developed at that point, and we could be adding clot to plaque. Um, but that study definitely does show that.
And another comment, and while estrogen may help your current cognitive functioning during the transition, it doesn't mean it prevents true dementia later.
True. Absolutely true.
Yeah.
Yeah.
Yeah. I can see where a patient who feels so much better and
Right.
cognitively intact would go, oh, good. Well, this is helping me so much now. It's going to mean that when I'm
Hmm.
85, I'm not going to have dementia. We cannot make that leap.
Right.
Is age 60 or 10 years post final menstrual period more important in terms of a
Right.
cutoff for routinely starting
I
MHC?
think 10 years post final menstrual period is much more important because a 60-year-old could have been in menopause for 4 years or 15 years. And those are vastly different, physiologically different women. And so, in studies, often we pick age ranges because that's what we've got on paper and it's approximating that distance. But when they pulled the Women's Health Initiative data, they reanalyzed it by age ranges. And that's where we get the 60 and above and the 65 and above. But then a second reanalysis was done by years from final menstrual period, and that really showed that 10-year mark. And again, it's all a spectrum. Yeah, it's not like when you're 9.95 years from your final menstrual period, it's fine. And on your birthday, everything changes. This is a spectrum. So, in anyone who's 7, 8, 9 years out, I'm asking about their cardiovascular health and their family history and what risk factors they have, because they may be more towards that 10-year physiology versus more towards that 5-year physiology. We have to be sort of nuanced in our discussion, our analysis of patients.
Yeah, you need more information, but I'm always looking at how many years has it been, not what
Mhm.
birthday have you just had.
Right. And, we have to use birthdays sometimes. Women had a hysterectomy don't really know when they're in through menopause. I usually ask them a lot about their symptoms and when they started and try to get an estimate from that. But, there are a lot of women we just won't know, and we have to make our best estimate. And, it's not to say I've never started a woman 10 or more years out into menopause onto hormone therapy. I have. And I've done it for very specific reasons. Most commonly, these are women who are still having severe and unremitting hot flashes. They've tried alternatives. They have not worked for them, and they are the super flashers. And I think, we all have all heard that word, the super flashers, the women who are going to flash for the rest of their lives. And if they have a clean bill of cardiovascular health, they're probably not at a ton of increased risk. And I think it's worth, for quality of life purposes, starting them. But I'm certainly not starting someone who's 15 years in on, like I had one woman come to me and say, well, my skin kind of sucks and I might get dementia. I'm like, yeah, that's neither of those is the reason to start hormones 15 years into your menopause. And she's like, oh, and it'll prevent cardiovascular disease. I'm like, nope, it's going to increase it now. Oh, and I have hot flashes. I'm like, really? Because you didn't when we started the conversation. So nuance.
Nuance, right?
Yeah.
Good. All right. Anything else about the dementia? All right, we're pushing on just about 7 minutes out. Do you want to go
How
into the
about I do a
cardiovascular?
real quick summary of the last one?
Sounds
Because I
great.
think it doesn't actually have as much in it as I wrote down. You know me. I can
Give us
never,
a
I,
cliff
I get so
notes on the
excited by a study.
cardiovascular.
So the last one I wanted to review was the cardiovascular disease after hysterectomy in the Nurses Health Study and Nurses Health Study 2. So this is published in the Green Journal in Obstetrics and Gynecology this year. And basically they took all that data from that big observational trial of the Nurses Health Study 1 and 2 and looked at all the women with the HIST and all the women with the HIST BSO, divided them up whether or not they used hormones, and looked at their cardiovascular outcomes because they have data for, you know, huge long periods of time on these women. And the Nurses Health Study is one of the studies that hinted early on that hormones might actually be protective. A couple caveats about this, which is they didn't prescribe hormones in this study. So these women were on whatever their doctors put them on. Um, they don't know if it was CEE, oral estradiol, transdermal estradiol in the later study. The earlier study, actually, it was mostly CEE probably. So this is a mixed bag of hormone use in the hormone category. But sort of the big takeaways were that the average ages were a little bit different in the two cohorts. Nurses Health Study 1 was a little older, Nurses Health Study 2 was a little younger. They were able to control for comorbid factors. So they were able to control for their medical history, smoking, a whole bunch of things. Um, the big takeaways were in patients with a hysterectomy and a BSO before the age of 60 and never used estrogen, there was a significantly higher risk of cardiovascular disease with a hazard ratio ranging somewhere between 1.2 to 1.29. Women who just had a hysterectomy maintained their ovaries um, and no estrogen use. Only the group that had that hysterectomy before the age of 46 had an increased hazard risk for cardiovascular disease. And in the estrogen users, whether it was estrogen or combined, they didn't mention combined because these are all hysterectomy patients, so probably not a lot of progesterone because that wasn't commonly used. Um, if they had their HIST and BSO less than 46 and used estrogen, their hazard ratio for cardiovascular disease was still high at 1.26. And that was statistically significant. If their HISPSO was age 46 to 50, it was slightly increased at 1.1, and beyond that, there was no increased risk. So, conclusions. The younger we hysterectomize a patient, especially if we give her a BSO, the higher the risk of cardiovascular disease is really what this is saying. Now, when I read it, I was struck. I'm like, why would a hysterectomy, if they preserved her ovaries, put her at higher risk
Me
for
too.
for this outcome? And I think what they said, they proposed that maybe the uterus has an endocrine function we don't know about. I think that's very unlikely. I think more likely is that in doing the hysterectomy, even if we leave the ovaries behind, we do some damage, and we do some damage to the vasculature, and there are unknown consequences that impact those ovaries long term. So we can't, yes, we should be leaving ovaries behind, but we need to be thinking about these women as a slightly different and slightly higher risk category. And estrogen may have benefit, but it's not perfect. Like if you're doing a very early hyst, we're not preventing cardiovascular disease by starting estrogen. The estrogen we give is not the same as what's going on in the body when it's made naturally. And I think that's a really important point. The ovaries, they do put out estradiol, but our estradiol is synthetic. It's not exactly the same. It molecularly looks pretty similar, but it's going to behave differently. It's going in a different way. It's a different route. There are differences. But also, we don't account for other estrogen byproducts and other progestogen byproducts that the ovary is making, and, all these other things that are happening from the ovary. We also don't account for what the T is doing, which may have a cardioprotective effect at normal female levels. We just don't know. So it's not a zero sum game.
But it's another plug to keep your ovaries if at all possible,
Yeah,
right?
that was better
Yes.
than not keeping your ovaries.
Yeah.
Absolutely.
And also remember too that you pointed out that hysterectomy may compromise blood supply to the ovaries. So I think those patients may have a higher risk of earlier menopause.
Hmm. They
Um,
do. There are some previous studies that show it does advance menopause, I think on average by a number of months.
yeah.
But we don't really know in that perimenopausal time what's going on with those ovaries that might be different than others.
Question: thoughts about decision making regarding oophorectomy in a 53-year-old with regular menses with bilateral dermoids? Keep
Ugh,
ovaries?
I don't know.
If
It depends.
possible, if possible. I mean, it depends on if there's much normal ovarian tissue
Right.
to
Keep.
preserve. Sometimes
Yeah.
there's not.
Yeah. Yeah. I mean, I think there's a difference between a 2 centimeter dermoid you can shell out relatively easily and the ovary still looks normal, and a 10 centimeter dermoid on both sides that leaves you nothing. Seven's pretty
7
big.
centimeters, pretty big.
It's pretty big. And if it's on both sides, you're not going to have a lot of great tissue left. The other thing is there are some patients who just make a lot of dermoids. So if you leave ovary behind, you may be in there again or another one.
At
And
least he's
dermoids are not,
53 and not
yeah.
43.
Yeah, no, that's true. I mean, you can always tell her that if it's easy enough to shell one of the dermoids out, you can leave behind that ovary and take the other, you can say you'll do your best. That's, in that clinical scenario, that's what I would tell the patient, that I'm not going to spend time and blood loss trying to save, the pedicle of a tiny ovary that's probably menopausal anyway. But if it's relatively straightforward, it's on the outside, I think I can save enough ovary, we can try. Well, good. Glad we agree.
All right. Should we now be counseling women about increased risk of cardiovascular disease with HIST at age 45? Yes,
I
I think
mean,
so.
I think we kind of have to.
Yeah.
I would counsel them that it's very low increased risk. And certainly chronic anemia from massive bleeding probably increases the risk of cardiovascular disease more. We're always balancing risks, right? And I think there are things in their lifestyle that are going to impact their risk of cardiovascular disease a hell of a lot more than their hysterectomy. So, like, they should be taking a statin if they have high cholesterol, and they should be exercising regularly, and they should be sleeping. And those things probably have 10 times the impact on their cardiovascular disease risk that having a hyst does.
Love to hear your thoughts on the new article by Dr. Sarah Glenn on tailoring transdermal estradiol for bone health.
I have not read that article. Where
Maybe
was
we
it
can review it
published?
next time.
There you go. I'll look
Yeah.
for it. I mean, the only thing I can say about tailoring transdermal estrogen for bone health is that, at the Menopause Society, they were very clear that all doses of estrogen protect bone. And we do have good data for that because, we have the Menostar studies. So I don't know if people know Menostar, but it's a 0.014 estradiol patch that doesn't require progesterone that was trialed in older women for bone health, and they showed good bone support even with that dose. So I can't imagine any of the doses we currently use would not provide some bone support. I know there's definitely social media out there saying, oh, you must get levels and you have to be above this level. There's no evidence for that. So um, I'll be interested. I'll look up that paper, see what I see.
Metastar is still available, and I know that because I have a patient who is on Menostar.
I've never had a
Just
patient on
yeah,
Menostar.
I have one. She just likes it because it's super, super low dose.
Yeah.
But that's how I know it's still out there.
Oh,
All
wow.
right. Last question, and then we'll wrap up. What are the clinical implications to discuss with patients from the testosterone study you reviewed, other than using the advanced lab technology to measure levels, which luckily our LabCorp in Seattle can actually do?
They can do it. They will not be covered by their insurance. So you better warn the patient they're going to get a pretty big bill. That's an expensive test. Um, they can use LCMS. They won't use it preferentially. So if you just send off a testosterone level, you're getting the old test. You have to specify LCMS. Anyway, um, so what are the implications from the study? The implication is testosterone's not dropping at menopause. But there is a recognized role for using it for libido at safely controlled doses. And I actually don't send the LCMS when I'm doing testosterone replacement for patients. I send the free and total because if they're above the normal female range, which is what I'm looking for at baseline, it's gonna register. And I use that test to make sure they're not getting into the above normal female range as I'm doing therapy because I don't need to know exactly what it is. There's no like one dose you need to get to for libido support. That's not what the study showed. I just want to know that they're safe. Oh, thank you. I appreciate the article. Means I don't have to go do my own PubMed search. But so I think the gist of Dr. Davis's group's article is that we need to counsel women correctly that it's not like they've suddenly fallen off a testosterone cliff. Their libido may have fallen off a cliff, but it's not testosterone's fault. Now, will testosterone work for libido? In some proportion of women, yeah, it will. And that's because we're using it for a side effect. If you give a woman a little bit more testosterone, she feels a little bit more like a 14-year-old boy for some period of time. That's fine. If it works, it works. Great. I'm all for it. But we need to be honest with them about what we're doing. We're not replacing testosterone. We're using it for an effect. And that's fine. There are a lot of meds we use for effect. We're not replacing things with. All right, guys. I think that's all we got for tonight. I'm tired. And Dr. Savage needs to go to bed because she's on Central Time, so it's much later for her.
Oh, I'm going across the street for dinner and a beverage.
Oh, well,
It's
lovely.
not
I
that late.
appreciate that. All right. Good night, everybody. I hope to see you next
Thanks
month.
all.
Bye-bye.
Bye.